Hi, I'm Christopher Westfall, today with an update about Medicare as it pertains to diabetes, a very important topic. This new study came out March 2nd, 2021 from the American Journal of Managed Care, goes into the details of what's different on traditional Medicare, which they call TM throughout their survey here. And then the other one is managed care, so Medicare Advantage. So they're looking at the difference of treatment of diabetes as it pertains to original Medicare versus Medicare Advantage. And if you know anybody that is diabetic, pre-diabetic, sincerely diabetic, or struggling with this in any way, shape, or form, and they're making a decision, a choice as to which plan they go with on Medicare, whether it's going to be managed care, Medicare Advantage, or open and free care, which is your original Medicare, this study might be relevant to that. So let's jump into the study. I want to show you some highlights, and I apologize ahead of time for reading from the study, but it's about 25 pages long. I've been spending 2 days with this study and then other ones to help me understand what this is talking about. Not an expert by any means. All I am is a licensed insurance agent specializing in Medicare choices for people, but this is relevant because a great segment of our society and our clientele as well, they are diabetic, so these choices are important to them. So let's take a look at the study. Again, this is from the American Journal of Managed Care, and this brand new study talks about, first and foremost, and you can see this study, by the way, I'll link it up in the description below this video on YouTube. You can check it out. Or if you're not on YouTube and you saw this somewhere else, you can go to my website, seniorssavingsnetwork.org/diabetes, and I'll have this study linked there. So done by doctor, a whole bunch of doctors here. American Journal of Managed Care, March 2021. The conclusion here starts off with Medicare Advantage enrollees are more likely to be treated with metformin and sulfonylureas and less likely to receive costly, newer medications than those in traditional Medicare. I'm just going to jump to the highlights here. This won't take long. I'll get to the point, and then I'll have some call to action at the end where you can figure out how this can apply to you or not. So the objective of this goal of this study is to compare the use of diabetes medications between beneficiaries enrolled in Medicare Advantage versus traditional Medicare. The methods. So this data came from over 1 million traditional Medicare folks and 838,000 Medicare Advantage beneficiaries. Later on in the study, it talks about how they weighted them to make them equal, who have received at least one prescription for an oral or injectable diabetes medication. After matching Medicare Advantage and traditional Medicare enrollees by demographic characteristics and geography, we analyzed use of medication overall, choices of first diabetes medication, that's important, for those new to medication, and patterns of adding medications later. So that's what they looked at. The original people, brand new to diabetes, what are they treated with? And then as if it progresses, a lot of times it does, what do they add and when? The results. Overall, and for patients on 1, 2, or 3 diabetes medications, use of metformin was higher in Medicare Advantage by about 3 points. Not very statistically significant. But use of newer medication classes was 5.1 percentage points higher in traditional Medicare. So for those who started metformin first, use of a sulfonylurea as a second medication was 7.8% higher in Medicare Advantage than traditional Medicare, whereas use of medications from newer classes was 7.7% lower. So that means that on traditional Medicare, original Medicare, the doctors are more apt to give you the newest, the latest drugs if they're better for you, as opposed to managed care, which is Medicare Advantage, which are more likely to give you the old, stable, traditional drugs because they're also generic too, and that's just cheaper. Conclusion, which I've highlighted here, Medicare Advantage enrollees are more likely to be treated with metformin and sulfonylureas and less likely to receive costly, newer medication than those in traditional Medicare. And that's pretty key. The takeaway points of this study, it says that Medicare Advantage is associated with decreased utilization. Medicare Advantage enrollees were more likely to use metformin and sulfonylureas and less likely to receive newer medication. There is substantial variation in the approaches to medication management across Medicare Advantage health plans. So original Medicare is the same no matter where you go in the country, from Maine, New Hampshire, all the way to California, Hawaii, Guam, wherever original Medicare is, it's the same. It's any hospital, any doctor, Whatever they say goes. There's no prior authorization requirements. There's no referral requirements to go to specialists and so forth. And as such, that freedom translates into the ability to use more drugs that are of the newer nature than the old standbys. Jumping down here to the highlights. Differences in choices of medication might be another method by which Medicare Advantage plans achieve savings compared to traditional Medicare. It's all about the savings with managed care. That's why you get into it. That's why the majority of the plans on managed care, Medicare Advantage, are free, no premium. How do they achieve no premium? By cost-saving measures just like this. Traditional enrollees generally enroll in standalone Part D prescription plans. And so this is where my expertise comes in. As a Medicare broker, I can tell you that if you get a Medicare Advantage plan, you generally get an MAPD plan. Medicare Advantage, Part D, they're all sandwiched together. You'll see this on many commercials like United Healthcare and Humana and the rest of them. They say, you can get an all-in-one complete plan with everything in the world all in that one plan. The small print of that is that you don't get to pick your Part D plan. Your Part D plan is just sandwiched in there with the major medical plan. And that may be good for some people, may be good for a lot of people, but it may not be good for a unique segment of people that have unique chronic underlying conditions. So for those people, what we've found in the past is there's a great disparity between a good Part D drug plan, again, individualized for one person, as compared to a generalized, cheap Part D drug plan, which is good if you don't take any medications at all. And we see that every year. There's always the lowest price leader out there who's going to be the cheapest Part D drug plan. That's the standby. That's the good old placeholder plan for one who does not need a comprehensive Part D plan. Those choices, everything from the cheapest to the best, are only available for those people in original Medicare, because when you're on a Medicare Advantage plan, in most all instances, you cannot go out and pick a unique standalone Part D drug plan that may be best tailored for you and then slap that into a no-cost Medicare Advantage plan. It just doesn't work that way. So traditional Medicare enrollees enroll in standalone Part D drug plans. However, no prior research that we are aware of has compared patterns of medication management in these two programs. Long overdue. Diabetes is a prototypical example of a chronic and often progressive medical condition that may be affected by managed care approaches. That's why it's important to look at this. Diabetes currently affects more than 1/4 of Medicare beneficiaries and is among the most common and costly chronic medical conditions affecting elderly Medicare enrollees, and that's why it's so important to look at this. So, the American Diabetes Association estimated in 2017 that almost $50 billion was spent on prescription diabetes medication and testing. Consensus recommendations uniformly support lifestyle modification, changing what you eat and what you do, plus metformin as the preferred initial treatment strategy for type 2 diabetes. But many classes of medication compete for use as second and third line therapy, and that's really what we're going to go into, including those new in the past decade drugs. More recently, some emerging data suggests improved outcomes with several new agents in high-risk populations with cardiovascular or chronic kidney disease. But health plans and patients who use these newer medications, which have no generic alternatives, also face higher plan and out-of-pocket costs respectively. So if you have a comorbidity with heart issues and diabetes, you might want to look into some of the newer classes of drugs. That's what it's talking about, as opposed to the old generic standbys that we've been using for decades. Recommendations specifically for elderly patients include avoidance of long-acting sulfonylureas like glyburide. They affect generally the pancreas and releasing more so that the insulin is coming from your own body, and that's what the long-acting sulfonylureas do. And when you have that drug, there's a tendency to sometimes go into hypoglycemia, where your blood sugar just goes far too low. And that's what we want to watch, especially with the elderly people that have multiple conditions that they're managing. And yet that's the old standby, and that's what Medicare Advantage still goes by. Recommendations specifically for elderly patients include the avoidance of long-acting sulfonylureas, which are associated with increased rates of hypoglycemia, and application of less stringent treatment goals for glucose control, particularly for those with limited life expectancy or multiple coexisting comorbid conditions. Previous research indicates that diabetes is among the clinical areas in which Medicare Advantage plans achieve their highest rates of savings for medical services. The little research has examined how choices of medications for enrollees with diabetes differ from those enrolled in Medicare Advantage versus traditional Medicare. Given the high cost of medical treatment of diabetes, we therefore used comprehensive data on beneficiaries being treated for diabetes in both Original Medicare and Medicare Advantage to compare pattern of drug use in the two programs, as well as a total pharmacological spending and adherence. Okay, so we'll skip down to the good part. We based our classification on largely consistent recommendations from the American College of Physicians, the American Diabetes Association, the American Geriatric Society for the Treatment of Elderly Adults with Diabetes during the time period of our study. Finally, we considered long-acting sulfonylureas, which we talked about, to be guideline discordant at any stage of treatment because of increased risk of hypoglycemia in elderly population. This term right here, guideline discordant, is a nice way of saying that's not the best way to go. Long-acting sulfonylureas, in addition to metformin. Generally, this is the second or third drug added to metformin if the A1C is not getting under control. So they're saying, we considered long-acting sulfonylureas in their studies on this to be guideline discordant at any stage of treatment. Okay. All analysis we're conducting using the software. Our study protocol was approved by the Harvard Medical School Human Studies Committee. This work was funded by the National Institute of Aging, which had no role in the design of the study or in the collection, analysis, or interpretation of the data. The largest Original Medicare versus Medicare Advantage difference was for use of any of the new classes of medication, which was 5.1 percentage points higher in Original Medicare, so 21% of the time. And again, this is best used in those people with a comorbidity, the older people, the more susceptible to really adverse effects of hypoglycememia. So that's where they're using these SGLT2 inhibitors as opposed to just regular old diabetic medication, especially for that second role after metformin. So its use is higher, 21.3% in traditional Medicare versus 16.2% in Medicare Advantage, because they're trying to save money. Those who started on metformin first, use of a sulfonylurea as a second medication was 8 percentage points lower in Original Medicare, which was primarily offset by the use of medication from the new classes. Again, Original Medicare affords you the opportunity to have the drugs that might best suit you as opposed to the drugs that are the cheapest, generics, and the easiest way to go. Now, why is that, and how do they enforce that? Patterns of use of diabetic medications for beneficiaries enrolled in Original Medicare and Medicare Advantage differ even after identifying enrollees at late stage of disease who either start medication therapy or require additional medication. More importantly, these prescribing patterns have important implications for both quality and cost of care. In contrast, medication choices in Original Medicare generally were costlier, with greater use of expensive new classes of medication as both first and second line treatment, leading to higher levels of both planned and out-of-pocket spending for traditional Medicare beneficiaries. But at least they have the choice. That's the point. They have a choice in Original Medicare. To achieve savings, enrollees in Medicare Advantage plans more frequently receive sulfonylureas, which have the potential to cause hypoglycemia in older patients. To achieve savings. It's not Chris Westphal saying that, that's this study. Our study found substantially greater use of diabetes agents that do not yet have generic alternatives as both first and second line treatments in Original Medicare. The use of some of these newer classes of medications could represent higher quality of care, particularly for higher risk populations with established cardiovascular or chronic kidney disease. For instance, emerging evidence supports the use of those inhibitors to treat specific high-risk populations with established cardiovascular disease or chronic kidney disease. Guidelines continue to recommend that the choice of second medication should be individualized based on patient preferences and potentially the cost. Should be individualized as opposed to guidelines that everyone has to go by, which is what managed care is. It's the management of the care to try to keep it as cheap as possible. Says here, health plans can employ financial incentives. Here's how they enforce it. Health plans can employ financial incentives to physicians and physician organizations that encourage use of preferred lower cost agents, thus delegating responsibility for management and prescribing patterns to these providers. For instance, some Medicare Advantage plans have entered into capitation-style arrangements with physician organizations. Interesting. That also put these organizations at risk for drug spending. Plans using management mechanisms like these might choose to discourage adoption of some newer and more expensive medication until their marginal value is clearly proven in the literature. Talking about cost. It will be important to monitor choices of medications in such plans to ensure that patients are not denied more expensive medication when they may be of benefit. Finally, plans also have direct control over their formularies. Medicare Advantage plans have direct control over their formularies. The formulary is the list of drugs that they will approve, that they will pay for. And integrated plans may make different choices related to inclusion, tiering, or cost sharing that can also influence the use of medications. So of course, it's all about saving money. The conclusion: we found substantial differences in patterns of medication use between beneficiaries in Original Medicare and enrollees in Medicare Advantage health plans. Although with substantial variation among health plans, Medicare Advantage plans are different. They could be different county by county and certainly state by state. The benefits are just a hodgepodge. We can't just say you're going to get Plan G Medicare Advantage plan in the state of Kentucky. Doesn't exist. What you can do is you can say your hospital copay will be this. Your doctor copay will be that. Your drug copay will be this, but here's the formulary and here's where it breaks down into tier 2, tier 3, tier 4 drugs. Different across the board. That's why a Medicare Advantage consultation could take 2 hours, where a Medicare supplement consultation will be, oh, your Plan G in Florida? Yeah, that's the same Plan G in California. Same exact benefits. Absolutely the same. But with Medicare Advantage, also note, if you're not yet aware, that those are calendar year plans. At the end of the calendar year, that contract is over. It completely starts over the next year. And in the next year, the things that can change are absolutely everything. Your formulary can change, the tiers can change, the drugs covered can change or can take them out completely. Had that happened this past year, lots of turmoil in the marketplace. Hospital networks can change, your doctor can change, your copays can change, the procedures can change, prior authorization lists can change. All of it can change in a fell swoop, including but not limited to, we saw a lot of this in Colorado in 2020, plans just completely leaving the market. Just completely leaving.
Care patients have suddenly been cut off from their go-to doctors. Austin Regional Clinic says they knew they would not be an in-network provider with United Healthcare beginning next year for Medicare Advantage patients.
But as KXAN's 𝐬𝐭𝐮𝐝𝐲 explains, that change seemed to have gone into effect 3 months earlier than expected.
ARC says they've heard from thousands of their patients.
Losing access to their doctor in a period of 2 to 3 days is just not right, not ethical, and we're very concerned about it.
But I like that plan. Sorry, it's gone. Those are calendar year plans. You have to pick another one if Medicare Advantage is your sole world that you occupy yourself in. That can completely change year to year. Substantial differences and variations among plans. Costly and complex regimens are used more frequently in Original Medicare than Medicare Advantage across all treatment levels, reflecting more frequent use within Medicare Advantage of medications that can cause hypoglycemia. In other words, sulfonylureas, the long-acting ones, and less frequent use of newer agents, which might be of particular benefit for higher-risk patients. These findings suggest that managed care approaches, adopted by at least some plans, influence diabetes treatment practices. As our health systems strive to find opportunities to lower healthcare spending and improve the value of care, chronic diseases such as diabetes present a substantial opportunity for cost savings that increase the value of care, but they also raise concerns about stinting on care that might ultimately benefit some subgroup of patients. Those concerns, that's why I'm talking to you about this study right here. So the choice is clear, and Medicare, Original Medicare, with a Medicare supplement, medigap plan, same thing, that fills in the holes of Original Medicare so that you're not exposed to a potential 20% of an unlimited number on Original Medicare. Original Medicare with a supplement is compared then, and you also get a Part D drug plan customized for you, compared then to an all-in-one plan that is designed from the outset to save the plan the most amount of money. So if you are on a Medicare Advantage plan and you find yourself going to the doctor more, having limitations with regard to how many times you can get a referral to a specialist, or getting the prior authorization necessary to get the treatment that you and your doctor agree with. Sometimes it's difficult, and the most frustrating thing about my job is to have the difficult conversation when someone is in their second, third, fourth, fifth year of Medicare Advantage, and now they say, you know what, I'm going in and out of the hospital. It's costing me $200, $300, $400 a day in the hospital. I have to go to the cheapest hospital. I can't go to the best hospital. My doctor leaves the network. I have to pick another one. Then he leaves the network. I have to pick another one. To hear all these things happen, they only happen when someone's in bad health. They're going through challenges. And typically that's not their first year in Medicare. The problem is this: once you're going through those things and you're trying to manage a chronic condition like diabetes and it's out of control, it's spiking, you're using insulin, you're not using insulin, you're not. When these things are happening, that's the time when people want to go from managed care into traditional Medicare. That's when they want to go to original Medicare and a Medicare supplement plan. The problem is you might not be able to do so, because going to a Medicare supplement plan to fill in the holes of original Medicare, thus making it a complete total package with freedom, flexibility, and massive out-of-pocket costs not on the table anymore, you need both a Medicare, original Medicare, and a Medicare supplement to go with that. That takes underwriting. Unless you're in open enrollment, brand new to Medicare for the first 6 months, hey, the world is your oyster. You can do anything you want to with original Medicare. You can add a Medicare supplement. You can jump into a Medicare Advantage plan. You can have a Part D plan. You might not have a Part D plan. Do whatever you want for those first 6 months. It's after the first 6 months that the choice that you made when you were brand new to Medicare, you may be stuck with for the rest of your life. And that's what we try to communicate over and over and over again. We're not looking at today's decision. We're looking at the choices and the options that you'll have throughout your entire time on Medicare. And let me tell you how that works. On Medicare Advantage, you can join a Medicare Advantage plan or change it every year during the annual election period. Some people call it the annual enrollment period. They're interchangeable. So during that period of time, from October 15th through December 7th, you choose what's going to be your plan, your Medicare Advantage plan, for January of that next year. So if you're on a Medicare Advantage plan, the good news is you can revisit that every AEP. Make your choice from October 15th through December 7th, and we've got a website. You can see all those plans. It's called MedicareAdvantageNearMe.com. Go look at the plans. You can see what's available. You can sign up for those plans during that period of time, or if you're new to Medicare. And then your plan starts in January. Then in January, they figured out, hey, you might not have liked that plan that you're on, so now we're going to have the disenrollment period, now known as the open enrollment period. If you're in a Medicare Advantage plan, but you see that another one might be a better fit for you, you can change during this next period of time called the open enrollment period now, from January 1 through March 31. It's weird, we have a blackout period. I guess it's time so agents can take a breath and take a breather and spend some time with their family. From December 7th to January 1st, we can't do anything. Can't take any applications, can't change anything, nothing at all. No marketing at all. From December 7th, midnight, to January 1st, when January 1st starts. It's open again January 1 to March 31 if you want to change your Medicare Advantage plan. Now, you can't get one if you didn't have one before, but once you're on that plan, you're locked in. And the interesting thing about that is, on Medicare Supplement, though, we talk about freedom and flexibility as a key component to original Medicare. The same is true with Medicare Supplement. You can start, stop, change, move out of, forget it altogether, your Medicare Supplement plan 365 days a year. As long as you can qualify through health underwriting, which are some simple questions that we have from all the insurance companies. In some states, you don't even have to do that. But in the majority of states, you have to go through health questions outside of your 6-month, your brand new to Medicare period of time. And then you can change your Medicare Supplement anytime. Like if you're on an old Plan F and you're paying sky-high rates, you probably should change your Medicare Supplement plan. If you're on a Plan G and you're seeing rate increases go crazy, you might want to consider either another Plan G or look at Plan N. So you can do those things year-round, which is one of the reasons I love this business. We can constantly help our people year-round to change their Medicare Supplement plans. But the Medicare Advantage, because Medicare Advantage takes everybody, they take anybody and everybody into Medicare Advantage plans. That's why the industry lobbied to have it into a small, finite period of time of the year that you can choose to get on their plans. Same thing with the Affordable Care Act, because it'll take pre-existing conditions and they have no health questions whatsoever. The industry says, what we don't want adverse selection, which means, oh, now I'm sick, now I want a plan. I have no insurance, I need a plan, I'm going to go sign up for that plan. How they get around that is a certain time of the year to get onto the Affordable Care Act plans or the Medicare Advantage plans. We don't have that with Medicare Supplement because there's the threshold of, can you health qualify? So back to the original thing. If you're on a Medicare Advantage plan and now you're seeing high utilization and you're seeing the restrictions of the networks and the management of the managed care putting binders on what you're allowed to have done, oftentimes that's the frustration is now that person wants the free and unlimited world of Medicare with the Medicare Supplement and they just can't qualify at that point for a Medicare Supplement. What we specialize in is looking at certain health conditions unique to each client, of course, and trying to match up the best Medicare Supplement that will accept you based on your health. If you're healthy as all get out, no problems whatsoever, not taking any massive medications or anything, then you can change plans anytime you want. It's a really quick application that doesn't even require a physical signature anymore. We do all the work for you. It's a very quick process, by the way, and you just get approved. And then your rate goes down, or you get the plan that you wanted. It's when we have people who have experienced the world of managed care to the detriment that it can potentially be if you're a chronic user of that managed care, those people then, once they've eaten that apple, the knowledge of good and evil, they're like, oh my God, this is what I have. Let me get off this plan. Then it might be too late. And that's the challenge that we struggle with. So if we could educate more people on the front end about here are your two paths to go. Original Medicare with a supplement and a Part D plan customized for you, or managed care, oftentimes zero premium, but you get what they package in there. And they'll put all kind of fluffy things in there too, like you'll get free dental. Look at the small print. Look at the limitations. Look what they cover. You're going to get silver sneakers. Well, that's going away with a lot of plans and only used by 7% of the people who have it. They say they want it, but it's not a game changer by any means. We're going to give you this free, and we're going to give you that free. We're going to give you a discount, discount. Right. At the end of the day, how does it treat me when I'm in the hospital for a major thing? Can I go where I need to go? If, God forbid, I get cancer, can I go to the Mayo Clinic? Can I go to MD Anderson? Can I go to Johns Hopkins? Can I go to anywhere I want to go? Or am I restricted to a small network where my choices regarding my health care are limited by someone who's trying to do utilization management? Another word for the cheapest possible way to get through that. And then your remedy is you can file an appeal. You can file an appeal. You can file an appeal. And as our study showed from the Office of Inspector General, more than 72% of those appeals are ultimately granted. They're going to ultimately give it to you in most of the time. But you have to sit there and wait on papers to be pushed and somebody to say no and somebody to say yes and somebody to say no. As opposed to that whole world being gone. Original Medicare, your doctor says you need surgery, book it. Book them, Dano. Go to the best place you can have that surgery done with the best doctor in that county or that region, that state, or the country on that particular thing, and you have it done. It's just a difference of choices. You can either save money now with a low premium, zero premium plan, or you can save money later by having potentially the life-changing choice to go and get the best treatment available in the United States. And I understand. Let me just say this again. Some people accuse me of being biased. I'm only biased because my mom is on Medicare, and I see how these things transact in people's lives on a daily basis and hear from hearing them. So that gives me a bias. My bias is toward my senior clients and for seniors in general. But I'm just saying not every plan is good for every single person. Not one plan is the same that everyone should be on in the whole world. We have to take a pause and listen to what's most important for you. What's your background? What are your health histories up to this point? What medications are you taking? And which trend are you going toward? So that's something we do in my office. If we can ever review your plan with you, it doesn't cost anything to get a second opinion. When we write an application, it doesn't cost anything. We get paid if we write something with whatever insurance company we find is best for you and what suits you best. We're independent brokers, just like your homeowner's agent. Your homeowner's insurance policy or your car insurance agent, they don't ever charge you for the benefit of running quotes for you or filling out an application for you and all that kind of stuff. There are some people in the Medicare world that call themselves counselors and consultants and things like that. They'll literally charge you to write an application, and then they get money from the insurance company too. I don't think that's even ethical or legal. I don't know how they do that, but we charge nothing for our consultation. And if we help you with a plan, great. If we tell you there's nothing we can do for you, we part as friends. At least you're a little bit more educated. But either way, our service doesn't cost you anything. We try to find the most appropriate plan, the best possible price all across the country. And we're licensed everywhere. So if we can help you, please reach out. My name is Christopher Westphal from the Senior Savings Network at seniorsavings.network.org. Our phone number is 800-729-9590. Thanks so much for watching. If you know anybody with diabetes, please share this study with them. Again, you can get this study at seniorsavings.network.org/diabetes. Be happy to provide it to you. It's publicly available. Anytime there's a news story about Medicare, you'll see it here on this channel first. So I encourage you to subscribe. Please give this video a thumbs up. It really helps the YouTube algorithm, that's a fun word to say, so that it can help other people to get to see the video. And comment below if you've had any experience with this, with diabetes, or know someone who has. Would love to join the conversation. That takes place in the comments below on the video. Thanks so much. God bless you. Bye-bye. Thanks for watching. I don't know why I put my dirty glasses on at the very end there, so I could see the camera. What point is that?